Good morning, I'm Jessica Lovell and welcome to the Morning Medical Update. Today we are meeting two women who were told to swallow radiation in order to fight their cancer. But their cancer isn't in their stomach or their gut. It's up here in their thyroid. An estimated 43,000 people in the U.S. will learn they have thyroid cancer this year. A majority of those patients are women. And according to the American Cancer Society, thyroid cancer is often diagnosed at younger ages, more than most other adult type of cancers. Thankfully, it is treatable and the survival rates are very good when the cancer is caught early. We are so pleased to have Dr. Erin Buczek with us. She is a head and neck surgeon here at the health system, treating a lot of thyroid issues, including cancer. Good to have you with us today.
Thank you for having me.
We also have Jennifer Osorio, who learned that she had thyroid cancer at the age of 29. Glad you're here with us to share your story. And also joining us remotely is Lauren Heim. She was diagnosed at age 34. So two young patients, both Dr. Buczek's patients. So glad to have you both with us. And I do want to start with Jennifer today because your thyroid cancer was actually found really by chance. You were getting treatment for something else. Tell us a little bit about that treatment.
Yeah, so I found out I had thyroid cancer kind of just by accident. I actually had the gastric sleeve done. And so when I had the gastric sleeve done, they found a stomach tumor when they took part of the stomach out. So they're like, we're just going to follow up on it with oncology just to make sure everything's okay. And my oncologist there was like, you're fine. Let's just do a PET scan. I don't think you have anything to worry about. And of course I go in for the PET scan. I was like, oh, it's fine. He said I'm going to be okay. But when I come out, they're like, oh, actually we found something in your neck. It looks like thyroid cancer. And then that's when it kind of all started, when I had to come back in for a biopsy.
So you were just thinking you're going in to make sure you were in the clear of cancer, and
right.
You come out and actually get this diagnosis. Dr. Buczek, how often does that happen where somebody goes in for something else and finds out they actually have cancer, and in this case, thyroid cancer?
It's fairly common from a thyroid cancer standpoint. In fact, a lot of thyroid problems, including cancer, are really picked up by accident, oftentimes on CT scans or PET scans, like Jennifer.
So, so how long? So after you had the surgery, how long was it until you were diagnosed?
I found out in probably early November last year.
And did you have thyroid issues before that?
Yeah, I actually had hypothyroidism, so I was already on medication to help with that. But nothing like to the degree of what I found out.
And you went in for the gastric sleeve surgery because you were actually trying to help with another issue, another health issue that you've been battling. Tell us about that.
Yeah, so I have congestive heart failure, and so kind of dealing with that, I went to do the gastric sleeve to alleviate some of those symptoms that I was having and then kind of just get my health better. And then after I had it, I was like, oh, this is great. And then, you know, more just decided to come up.
Right. I call it like kind of the 1-2 punch. You were trying to fix one problem and then you come out with something like that. I mean, when you met her, it must have been like, wow, here's a woman trying to take control of her health and do the right thing. And now we have a whole new issue on our hands.
Oh, yeah. I remember looking through her chart and just thinking, how unlucky.
Unlucky. Yeah, you probably hear that a lot. It is just about luck. I do want to show some before and after pictures because I think people like to see that. You go in for the gastric sleeve to, again, help with some of your heart issues. Tell us about what that journey has been like.
Yeah, I think it's been a learning curve for sure. I think anybody who does like the gastric sleeve understands that. Like it's a life change. But it's definitely been probably one of the best decisions I've ever made. I think the before and after pictures speak for itself.
They do.
I think it's, you know, it's going to be a lifelong thing.
It is. Yeah, it's not a decision you make quickly.
Right. Yeah. It was not something that I was like, yes, I'm going to just do it, and then, you know, it's a one and done. But it's not. I think it's for sure it's been over a year since I've had it done, and I think it's still to this day I'm still learning how to, you know, work my way around it when I go out, just eating in general.
Yeah, it's not just body, it's a mind game for sure. And just, are you feeling better?
Yeah, I think it's definitely helped with like my heart failure. I've had, you know, a good doctor here at KU2 who has told me like, this is amazing, you know, it's only helping you in your future. So
good job. Yeah. Well done. Well done. Okay, so Lauren, I want to bring you in as well here because you were diagnosed in April, not too long ago. When did you realize something wasn't quite right?
Well, I was on a FaceTime call with my sister, and I'm looking, as you do, looking at yourself instead of her. And I'm noticing that my neck looks a little lumpier than I think it should. And so I'm quite fixated by that. And so I end up having my OBGYN look over, do my full body check for my annual exam. And she's talking to me, feels it once, and then she didn't say anything. And I said, would you mind checking that again? Because I think there's a lump there. And so from there, an ultrasound was ordered.
Yeah, those Teams and Zoom calls, they certainly reveal a lot of what we think we look like in real life. So interesting. Yeah, you're kind of looking at yourself going, what is that? But that's interesting that you noticed that. Were you feeling it then? Did you feel it? You see something, but did it feel different?
I know I have read and heard that, you may have problems swallowing, and I did not have any of that. It was more so that I just noticed something, physically could see it. And I thought that's a little concerning. And so I'm glad I went right in and was able to get an ultrasound pretty quickly after that.
And what did they say at first about that lumpy throat? Like, yeah, glad you came in to get checked, or, was it something that they were alarmed by?
Yeah.
What were they telling you about that lump?
They told me, I got a call pretty soon after, that there were 2 highly suspicious nodules. And so, of course, that was pretty concerning. And I had 3 nodules total, though. And so a biopsy was ordered at that time.
So you eventually officially get diagnosed with cancer. What was that moment like?
Yeah, I actually had to do 2 biopsies. The first time I was told it was benign, and then an endocrinologist said, go ahead and test all 3. I'm very grateful for that, or otherwise to this day I wouldn't know I had cancer. But I have had a family history of benign nodules, so I was quite surprised that it was cancer. Both my husband and I were just really shocked to hear that news, for sure.
Yeah, you hear the word, Dr. Buczek, a nodule. We feel nodules and, things that are a little weird on our body, but to know that that's going to turn into a cancer, very, very concerning. Just when you look at both of your patients here, both had similar treatment plans, which we're going to talk about, but both discovered them in very, very different ways. What do you make of that?
I actually think that's fairly common. And nodules are tricky because actually most thyroid nodules are benign, as Lauren was alluding to. So it's really trying to figure out which ones need to be worried about more, which ones need a biopsy, and that's where having a really good ultrasound really comes into play. Now, Jennifer's was a little bit different because it lit up on a PET scan, which automatically made it more concerning than, say, most thyroid nodules are. But Lauren found it where she felt it or saw it or someone else noticed it is also pretty common.
I've heard of those stories where somebody else sees you and notices it in you and says, hey, that's an interesting lump, and I think you need to have that checked out.
Or even like doing something online, like you said, Teams or something, and someone points it and goes, hey, what is that thing on your neck?
Not what you want to hear.
Not really what you want to hear, but good that someone's pointing it out, and definitely needs to be checked out.
Yeah, looking out for each other. So let's get back to the basics. Just what is the main function of the thyroid?
Yeah, thyroid does a lot of very important things in the body. Its main role, to sort of summarize, is all about homeostasis and metabolism. So it plays roles in weight gain, weight loss, heart rate, just temperature control, regulation. In women, it controls menses. It does basically a lot of things in your body. The way I like to explain it to patients is if your thyroid is underfunctioning, you're going to feel really sluggish and tired and sort of just worn down. And if it's overfunctioning, it's the opposite. You're going to feel amped up, you can't sleep, you're losing weight, your heart's racing. And so we really want it to be working nice and even, right in the middle.
So what you said you were having thyroid issues before. What was it, overactive, underactive? Underactive. Okay, so what type of symptoms were you having? Very similar to what Dr. Buczek said?
Yeah, tired, just a lot of fatigue, didn't want to do a lot, feeling slow.
Right. Lauren, did any of those signs, symptoms sound familiar to you? What were you feeling?
Yeah, I have a lot of hormone imbalances, so it's hard to know, what was going on. But all of my blood work was fine, even up until surgery, strangely. So
are there different types of thyroid cancer? How do you compare between the two ladies here?
Yes, there are different types. The most common type, which both ladies had, was called papillary thyroid cancer. And that is frequently diagnosed at younger ages as well as older ages. But there are other types of thyroid cancer as well. There's another type called follicular thyroid cancer. another type called medullary thyroid cancer, which is completely different than the two that they had, but much, much, much less common. By far, papillary is the most common.
So why do we tend to see with thyroid cancer, why do we tend to see them diagnosed in earlier ages?
Has to do a little bit just with the disease itself. It often can have some genetic component to it, and it's not particularly well understood in most people why, but we find that thyroid problems tend to run in families. So like Lauren said, she had a family history of benign thyroid nodules. You'll see another member of the family maybe has hypothyroidism or hyper, but it's really common to see that where there's multiple people in one family who have sort of thyroid issues, and cancer can be one of those.
Jennifer, had you noticed anything in your family?
No,
Not a thing.
I even did genetic testing to make sure, because my mom got diagnosed with breast cancer. I was like, is there something? And they're like, no.
Really? Let's talk about the genetic testing, because that's really important to know what kind of, early precursors you can know. But does breast cancer, any other kind of cancer, would that be telling? And how would somebody know?
Typically for thyroid cancer, there's not a huge association with other types of cancers, but specifically for medullary thyroid cancer, there is a very well-known genetic predisposition. So if someone has that, we automatically recommend genetic testing.
So she did the right thing getting screened because her mother had it, but it's not like something's going to pop up and say, oh, yep, you have a risk of thyroid cancer.
Correct. I think it's just with the age in particular. Anybody who's diagnosed at a young age with cancer, we want to do a thorough genetic screening to make sure that we're not missing something else. Plus, Jennifer also had another tumor herself in her stomach, and so we really wanted to make sure that we weren't missing another genetic component to this.
I love hearing, though, that she said, my mother had it, so I got screened. Do we hear that enough, or do we need to talk more about how people need to be getting screened when they have somebody in their family that's gone before them?
I think it just depends, and I would talk with your doctor because it really varies between the type of cancer that they had, the individual in the family, as well as the patient. But frequently is an age thing. But yes, if there's a strong family history of ovarian or breast cancer in particular, especially for young women, we're pretty quick to jump on the genetic testing. It's very easy to do. It's just a blood test. So there's really not a lot of risk in doing that.
Right. It's a really good heads up. Let's talk about treatment. Is surgery usually the plan A?
Yes.
And what does that entail?
Yeah, typically surgery is first-line therapy, especially for papillary thyroid cancer and most thyroid cancers. And it varies on whether we recommend taking out half of the thyroid versus the whole thyroid. And it can be a little hard to know right off the bat. In fact, in Jennifer's case, we thought we would be able to treat her cancer with just taking out half because of its size. It was very small. But once we actually got it out and took a look at it, realized that it was maybe a bit more aggressive than we had originally thought, just because we couldn't look at it. And then we actually had to go back and take out the other half of her thyroid at a second surgery. Obviously we don't love doing 2 surgeries if we don't need to. So the more information we can gather before we do any operating and we can make a better judgment call, that's what we're trying to do. But sometimes you just don't know until it comes
you
out.
get in there, yeah.
Yep.
And Jennifer, I'm sure that's a good peace of mind to know, just get it all out of there.
Yeah, I was like, oh, it's fine. And then the second time when they told me that, oh, there's a little bit more, and I was like, I just want to get it done.
Get it done. I noticed your scar here. Do people ask you about that? And what do you tell them?
Nobody's really asked me, but
except me right now, of course. Okay.
One person did ask me at the store one time, and it was uncomfortable because it's one of those things that I don't really pay attention to anymore. But I'm just like, yeah, I had cancer, and I'm sure they feel bad on one side because it's not something you're like, they expect to hear.
Yeah, they ask, and they're hoping you're not going to tell them it's something as devastating as a cancer diagnosis. Lauren, the same question to you, because I know there were some pictures of you where you kind of were showing off the area there. When you get asked what that is, do you use it as an opportunity to educate and share? Do you feel uncomfortable? How should people approach you?
Yes, I remember the first time I went for a walk, like shortly after I had surgery, and I kind of noticed someone staring. And I felt uncomfortable at first, but now I'm trying to wear it as a badge of honor. Like, it took a lot to get here, and I'm kind of proud of it. I mean, I think it'll take more time, but I definitely encourage everyone to check their neck. So it's like a walking banner for me.
Walking banner. I feel that way too. Yeah. You wear it beautifully, trust me. So we know that the throat can be a complicated area. Does surgery affect anybody's ability to breathe, eat, anything in that area?
Yeah, absolutely. It is a very delicate area. We're working around the airway, the esophagus, and some of the nerves that go to the voice box. And so Really, the biggest complication or biggest concern from a normal thyroid surgery is the nerves that go to the voice box, which can genuinely impact how someone talks and speaks. It can also impact breathing if there are some more significant complications, and sometimes swallowing as well. Certainly in the short term, there's going to be some swelling and pain from surgery, which will impact swallowing. Usually those get better with time, but the voice is really the one thing that we're super concerned about, because we can have an impact on that even if you have a perfect surgery just from scar tissue and other things that can happen.
So Lauren, you shared some photos before and after your surgery. Tell us a little bit about that experience and how the recovery went for you.
Yeah, well, as an anxious person, this was me crying in pre-op to Dr. Buczek, and I definitely was nervous, but this was also my stay at one of the beautiful hospitals at KU. My experience was really positive. I stayed one night. My recovery was really smooth. I did have some temporary damage, or, my vocal cord was temporarily stunted or damaged a little bit, but it came back fully. So really just a positive experience with the surgery, and I anticipated it being really scary, and it went really smooth.
Well, we hear you loud and clear today. Your voice sounds great, so I don't think anything went awry there. Jennifer, was the experience for you as well as it was for Lauren? Tell us a little bit about that for you.
Yeah, the second time I went, I mean, the first and second time was really well. The first time I was just a outpatient, so I was there, came and went the same day. The second time, I went and I was like, oh, I'm leaving. And then they're like, actually, you're not. Like,
not so fast.
because of my calcium levels. And after they told me like, hey, you're not leaving, I had a meltdown because I was like, I want to go home,
Sure.
And so, but it was fine. I think I had a good experience.
Yeah, meltdowns are totally fine.
Yeah.
We got you. We're good. So on top of the surgery, there's also something called radioactive iodine therapy. I had not heard of that. I'm sure many of our viewers have not either, where you literally swallow radiation. Tell us how that works.
So the idea behind radioactive iodine is that thyroid tissue takes up iodine, and it's fairly specific to thyroid tissue. And after surgery, if there are any cancer cells or even normal thyroid cells, the idea is that the radioactive iodine can wipe out whatever is left. The problem is it doesn't work if you have a significant volume of thyroid tissue left, which is why you really can't give somebody radioactive iodine without having surgery.
Because it needs a place to go, right, and fix? Is that
right.
what you're saying?
It's too much if there's normal thyroid tissue, and they're able to just go to the normal thyroid, and it wouldn't go to any of the cancer cells. You'd have to give someone like a huge, dangerous dose.
Correct. So do you have to be isolated then for days?
You do.
Tell us about that.
And it is dose dependent, but we do recommend isolation. Now, a lot of people can do that in their homes as long as they can have like a bedroom and a bathroom to themselves for 3 to 5 days. And it does vary a lot on what your home situation is like. If you have young children or pets, you have to isolate from them for longer. But most people can do it in their house, but we do have to admit some people to the hospital who simply have no way to actually isolate from other people because you are radioactive for a brief period of time.
Jennifer, tell us more. What was it like for you, and what form did this radiation come in?
I haven't done it yet.
Oh, you haven't done it because you're not doing yours until later, is that correct?
I'm doing mine in January. I just got a call yesterday about it.
So how does it sound, hearing it from Dr. Buczek, this experience?
At first, I was like, I'm just going to do it at home. But then I changed my mind. I was like, I have pets, and then I have kids. And I was like, I don't think I can be away from them for that long, especially my dogs. I think it's going to be difficult. So I was like, I'm just going to do it here. I think I would feel more comfortable that way. I'm not, around anybody. But I'm excited to have it done. I'm ready to just have the last step of this and
get this behind you.
Yeah.
Like really start 2024 off right.
Yeah.
Lauren, you get your treatment after Thanksgiving. Is that correct? What kind of prep work are you having to do to get ready for that?
Yes, I am currently on a low iodine diet, so I will be doing that over Thanksgiving, but it is limiting. It's like no dairy, primarily, I think is one of the big ones, limited meat, but it's not too challenging. It's only 2 weeks, so I'm ready to just get this over with and start 2024 in a good positive step.
Yes, I like that. Okay, be sure to ask your questions. You can use the YouTube, you can use the chat on Facebook, you can tweet us or email the Medical News Network. Info is right there on your screen. Let's check in with Dr. Dana Hawkinson, who is actually seeing patients in Olathe this morning. So we miss you here in the studio, but glad you found a webcam you could join us by. But also, we want to talk about these COVID numbers. Have they gone up this week?
Yeah, hi, thanks. Yeah, down at Olathe this week. It's been great so far. We'll see how it goes, but it's very nice and great care and just helping all the patients down here as well. Yeah, unfortunately, Jessica, the numbers have gone up just a little bit. We went to 24 active inpatients. It's a jump from, I think we were at 16 last week, but also it's kind of higher than our most recent peak of 22 active inpatients. So again, we know that the virus is circulating out there, and again, we are getting to that holiday period where everybody will be out and gathering with their friends and families. So it's very important to remain safe and have a plan.
All right, Hawk, as of this week, the government will send out another batch of COVID tests completely free. All you have to do is fill out a form at covidtest.org. Hawk, let us know, though, remind us, if we start to feel sick, should we take those COVID tests right away, like on the first day when we feel those symptoms, or should we wait a little bit to be more accurate?
Yeah, I think that's great. And then that kind of goes to what I was saying with the plan. So you're exactly right. I think it is important to, when you start having symptoms, to test. But unfortunately, you may have to test 2 to 3 days in a row if you have a negative test and you are still having symptoms, especially if you know you've been around people and other people that you know are ill. It is vitally important to retest either 24 or 48 hours later. You may have to do up to 3 tests. We know that the sensitivity of the test, the ability of the test to pick up the infection, is low, but it does get higher at 2 to 3 days after symptom onset. But I think mostly it is vitally important to have a plan. So if you are symptomatic, please test. You can either call your doctor's office to try and get a PCR test, or you can test at home. But with the home test, you may have to test 2 to 3 days in a row to get an accurate diagnosis. If that is true, especially if you are high risk and you are positive, it is vitally important to talk with your healthcare provider and your doctor to try to get on those oral antivirals to reduce your chance of hospitalization and severe disease. Those oral antivirals continue to work very well. And as far as the government tests go, that is a good thing, as we can order now new ones, new free ones. We know that there was an initiative in September where you could still order. I understand that you can still order those. But you can also order this new batch, and especially if you are having to test 2 or 3 times, you will go through those tests fairly quickly. The government is also saying if you do get tests from them with expiration dates, that is still okay. They have increased and prolonged those expiration dates, but you can also always go to the FDA, or on the box they have QR codes that you can look to see if those expiration dates have been prolonged as well. So that is vitally important to know as well.
All right, 'tis the season, Doc Hawk. Thanks so much. We'll get on it. Go to covidtest.org. You can fill out that form and get those free tests. You'll need them. All right, thanks, Hawk. Well, one of our health system doctors was recently called to Capitol Hill to deliver his thoughts on using artificial intelligence in healthcare. Dr. Keith Sale, Chief Physician Executive of Ambulatory Services, testified in front of a Senate subcommittee. He said he's already using IA to help take notes during patient meetings.
I can now walk into a room and have a conversation with the patient face to face with them the entire time and not have to work with the computer itself. And artificial intelligence captures that conversation and puts it into a documentation for me into the EMR or the electronic medical record, where I can then evaluate that note for consistency, for accuracy based on the conversation, and then sign off on it. And so it's really allowed me to move through my clinic day a little bit more effectively, but also to really engage my patients a lot more effectively.
And by IA, I mean AI, right? So get that straight. Dr. Sale said that he doesn't think that AI will replace physicians, but it will enhance the work that doctors do. Let's get to some questions from our viewers this morning. And Yen Liang has one. After a thyroidectomy, will there be a certain degree of impact on the regular parathyroid calcium? and the control of swallowing by the current laryngeal nerve?
Oh, yeah, that's a great question. So
Thanks, Yen, for all the big words this morning. Okay, so what can you tell us about that?
So to answer the first question about parathyroid function, in most thyroid surgeries, the parathyroid glands, we're trying to leave them in, and you have 4 total that live next to the thyroid, but they're really small, very delicate, so it's common for them to get temporarily stunned after surgery, but almost always they recover with time, and that's one of the things that we struggled a little bit with in Jennifer's case. Was she had some stunning to those parathyroid glands, but over time they have recovered. With regards to swallowing, usually the recurrent laryngeal nerve is more involved with speech and voice, but you can have some issues with swallowing related to that or another nerve that lives near the thyroid, and mainly that can have to do with it putting you at risk for aspiration if 2 of those nerves don't want to work. But there can also be some scar tissue of the muscles that help you swallow, and that's actually really what comes into play when it comes to swallowing, is these muscles can get tight, they can get scarred down, and it can make it a little bit more challenging to swallow.
Question is, are there any long-term risks using that type of radioactive treatment? Is there any side effects long-term that we know of?
Yeah, absolutely, and there can be. So we don't use radioactive iodine lightly. One of the biggest risks is going to be dry mouth, because the salivary glands also take up that radioactive iodine. So the iodine can burn some of those glands and reduce their function, which leads to a dry mouth. Now, usually that's dose dependent, so the higher doses are more at risk for that. But that is one of the reasons why we tell patients to drink a lot of water while they're getting radioactive iodine, to try to flush out the iodine from those salivary glands and reduce the risk of that happening.
That was another question somebody had. How do they get that out of their system as quick as possible?
There are some other risks of secondary cancers. It can impact fertility, but typically those are at really high doses, and we don't give people that high of a dose, particularly after one time. But some patients who've been dealing with cancer for years and years and years may have a recurrence later, and they might need more than 1 round of radioactive iodine, and that's when we do start talking about some of those risks.
Question for Jennifer: does your congestive heart failure, did it complicate your treatment for cancer? And what kind of conversations did you have to have with Dr. Buczek?
I don't think it really complicated anything. I think they're really a good team here that I have at KU, and I think they communicate pretty well about, you know, am I safe to have the surgery? I think anytime I have surgery, I need clearance from my cardiologist, because I want to make sure that my heart is functioning okay. Just in case, is there a cardiologist on staff to have surgery?
Yeah. Everybody's working in tandem.
Right.
Because it's not unheard of to have a patient who has an issue, has another issue that they're handling down the hall that's completely unrelated.
Surgical risk is surgical risk, and so we're very aware of that. We do everything we can preoperatively to optimize patients, but it really boils down to having a great anesthetic team and making sure that if something were to happen, she's in the right place, and that, yes, we have cardiology right around the corner who can come help.
Last question: who's more likely to get this type of cancer, women or men, and why?
For papillary thyroid cancer, it is definitely women, about a 3-to-2 ratio. Why is a good question. I don't really if we really understand why necessarily, but women tend to get thyroid problems more in general. So it's likely to do with that.
All right, I want to get our takeaways today. And Jennifer, I want to start with you. First of all, just thank you for coming on and sharing your story and just being open about that. What do you want people to take away from your experience?
I think definitely following up. I think, you know, when I found out after my gastric sleeve, I think I'm so grateful that it happened by chance, but also following up on that, not just taking it like, oh, you're fine, like, don't come back, you know. But I think with my history, I'm very, I try to advocate for myself, and I'm like, you got to go. So don't put it off. Just go to your appointments, smart. Even though it's scary.
Yeah, smart woman. Great advice. Lauren, what's your advice? What's the big takeaway from your story?
Absolutely agree with everything you said. I think, yeah, just go to your primary care doctor or your OBGYN and get your necks checked and advocate for yourself. Speak up if things look off, and don't be afraid to feel silly, but it's better to be safe than sorry.
Well, and I think looking out after each other too. I mean, I love that your sister said, hey, there's something weird going on here. Let's get this checked out. Don't be afraid to tell somebody. You could really save their life, is what I'm hearing.
Absolutely.
What's the takeaway?
I think I would agree with both those sentiments. Always be an advocate for yourself. Never be afraid to ask for a second opinion if you're not sure about things. And when you're looking to figure out, well, how do I tackle this? Early intervention is good. Getting in early, being proactive. All of those things can really save your life, because the earlier we catch this, the easier it is to treat.
Well said. Thanks to all of our guests today. Thanks to our viewers for being with us, and we will see you back here tomorrow at 8. Steve Tone's heart may belong to KU, but his new kidney is all K-State. I'm Jessica Lovell on the next Open Mics with Dr. Stites, the connection between rivals that saved Steven's life. Wednesday at 8.
Subscribe to our morning medical update and Open Mics with Dr. Stites podcast. Now everywhere podcasts are available.